Hello everyone. Today we're going to talk about transcutaneous pacing. This has been a topic here at MCHD Clinical for the past couple months regarding when do we pace and how do we recognize if our transcutaneous pacing is working or not. This is a nerve-wracking situation for paramedics. So let's talk first about who we pace and when pacing is going to be successful. Well, these are unstable bradycardic patients. But remember, the patients who this will work best on are the patients that have a primary cardiac electrical problem. That's things like a third-degree heart block or sick sinus syndrome. If the problem is electrical and primary electrical, then our electrical intervention should work. Let's say we have a big RCA lesion or a left main coronary artery obstruction. If the problem is plumbing, it's less likely for transcutaneous pacing to work. If the problem is systemic, an overdose, sodium channel blockers, for example, a hyperkalemic end-stage renal disease patient, maybe a PE or sepsis. If it's a systemic problem, it is exceedingly unlikely that transcutaneous pacing is going to work. So from that standpoint, we want to start with pharmacology first, push dose epi drip, plus or minus atropine, all before we get transcutaneous pacing going. And I know that the classic teaching is that atropine does not work on higher grade blocks, but really in almost all situations minus heart transplant patients, there's not a ton of harm with atropine. So I believe we should throw pharmacology at these patients fully before we transition to transcutaneous pacing. So if we're going to pace, we have to be mindful and recognize both electrical capture and mechanical capture. So how do we do that? Well, first let's start with a monitor clip of a bradycardic patient. And here we see a bradycardic rhythm with a bradycardic pulse ox pleth waveform, no pacer spike. So this is our starting point. If we're going to pace this patient, then we'll see our pacer spikes on the monitor. What happens if there's no electrical capture? So let's use that example next. And on this slide, you'll see a pacer rate of 80, and there's absolutely no correlation between those pacer spikes and the QRS complexes on the slide. Our second example shows the same thing, pacer spikes and no QRS correlation. The added piece on this slide is that you can see the pulse ox pleth waveform is still markedly bradycardic, not at the rate of 80 where the pacer is set. So what happens when we get electrical capture? How do we determine if there's mechanical capture or not? So let's look at a slide that demonstrates this. As you can see, there's a pacer spike and a QRS complex with a T wave for the most part after every pacer spike. So in this situation, we have electrical capture. But if you look at the pleth waveform, the pulse ox, you'll see that the rate is still in the probably 30s, and the pacer is set at 80. Pulse ox is 96. It's a good quality waveform. So the lesson from this slide is that for electrical capture, we need to see a pacer spike, we need to see a QRS and a T wave. But for true mechanical capture, we are always going to check that pulse. But if our pulse ox pleth waveform is still slow, it's highly unlikely that we have true mechanical capture. Why is mechanical pulse checks problematic? Because we know we're not great at mechanical pulse checks, manual pulse checks. And with a patient jerking at 100 milliamps or 120 milliamps, it's even harder. So let's show an example of mechanical and electrical capture on the same monitor shot. And here you can see pacer spikes, QRS complexes that match up. And then below that, you see the pulse ox pleth waveform at that rate that is set above. Now, you're probably going to feel a pulse in that situation too, so I'm not telling you not to check a pulse. But if you think you feel a pulse and your pulse ox pleth waveform is 40, you probably need to redirect. It's highly unlikely that you have true mechanical capture at that point. As always, send us questions or ideas. We'll be back with another episode soon.